Good afternoon. Is everybody here? We've got a couple of stragglers coming in, but I think I'll make a start. I hope you have all had a good lunch. We're going to keep this afternoon quite racy to make sure that everybody stays awake. So there's going to be plenty of action. And we'll have good opportunity for interactive conversation as well. God, I'm not used to speaking to one of these microphones. Is that too loud? You okay? Cool. Okay. Welcome back, everybody. I'm Toto Grunland, and I'm co-chair of Theme 2 with Bridget Pratt. She will come and talk in just a moment. But I wanted to introduce this session, which is on applying marginalised voices in research prioritisation. And we have case studies of two types of James Lind Alliance approaches to share with you. What do I do? Next slide. Green button. There we go. So I'm going to spend a couple of minutes just telling you a little bit about James Lind Alliance. And the reason for it is that I'm a James Lind Alliance advisor. So I know a little bit about it, but I think you'd hear a slightly different story from any of the advisors. Here's a James Lind Alliance timeline, and it's actually been around for quite a long time, from 2004. The actual guidebook and methodology was developed sort of between 2007 and 2010, which is, I think, when the first guidebook was published. And the process has been developing and learning. It's very much a learning type of process all the way through to being established in Canada and being used through our Canadian hub out there. We celebrated our 50th priority setting partnership in 2017, and you can see how it's accelerated because in the last few years we've done over 100 priority setting partnerships. Now, I wanted to dispel a few myths, because there's a lot of myths around James Lind Alliance methodology floating around. Even in the published literature, there's quite a few issues which aren't entirely correct and certainly not accurate anymore. Happy to talk about that during break time. I could go into it in a lot of detail, so I won't. One thing is, James Lind Alliance is an initiative. It's not an organization. There are about 4 people who work with the National Institute of Health Research, who sponsors the JLA, who kind of are custodians of the process. They keep the website alive, they keep correcting the guidebook, updating it as we develop, and they train James Lind Alliance advisors, and they also work with potential priority setting partnerships to get them ready to actually do the James Lind Alliance method. So what's not shown on here in the process diagram is the amount of preparation that actually goes into actually just starting it. So there's a lot of prep work. This slide shows you there's actually 7 steps to the process. The little symbols on the left indicate, for example, the steering group, which is a diverse group of people who are absolutely fundamental to the process, who have been selected and recruited as key stakeholders of the process. And as you've heard from others, one of the great principles is that that steering group is largely composed of people who will be end users, people with lived experience. It's a very grounded approach. We don't include, I think Mona said earlier that what's nice about the JLA is we're very explicit about the inclusions and exclusions in the process. And we tend not to include researchers who already have a big influence on the research agenda in something like the steering group, nor the consultations. The second stage, this is hard because I usually walk around the stage. The second stage is there's a sort of a population graphic trying to show, oh, don't worry, it's only a couple of minutes. The second stage is a population stage. We consult with lots of people to ask them what their unanswered questions are, what they would like to see researched. Then we go back into analysis mode together with the steering group so that there is involvement from ground up in analyzing all those responses. And then we go into, I can't see, the evidence check. Oh, yes, the evidence check. And the evidence check tends to be just a kind of a validation exercise to make sure that those really are research questions. So we're not asking about things that have been answered. And then we go back into the kind of wider consultation. So we involve huge numbers of people by whatever mechanism is appropriate. And we consult with them about, asking them what their priorities are out of all of those initial questions that were submitted and that have been summarized. So there's a big sort of stage of prioritization involving a wide input of views. And that kind of reduces the long list of possible questions into a shorter list of questions, but still quite a long list. And those questions then get taken into the final priority setting stage, which is actually a consensus workshop, which involves people and conversations, and in particular, listening, a really key feature. So we have three stages where we involve people, two that involve wide range of stakeholders, and then the third stage, which involves a smaller group of stakeholders involved in conversation, into dialogue, to actually really get the nitty-gritty of what's important and set those questions into a sort of a ranked order. Now, what's key is what's different about the James Lind Alliance to some of the other methods, and other methods are available, it's okay, but what's different about the JLA is that there's no criteria. We don't expect our stakeholders to understand what's feasible or what produces social value or any of those things. There's no criteria. They make their own criteria, and they do that in a shared process, either individually or in a shared process at the workshop. The other thing that's interesting is that the result is a top 10 set of priorities or a set of ranked priorities. And I say a set of priorities, it's not the set of priorities. The aim of the process is to include something in the research agenda which matters to people. It's not necessarily the definitive one, and if we did the exercise again in 3 months' time or even the following day, it might be a slightly different result, hopefully not too different. But we're not trying to pretend that we've got the complete answer, so it's quite a humble process in that sense, that we're just adding to the research agenda. An observation that was made recently by a study at Oxford University is that 45% of the top 10s in JLA priority setting partnerships up to, I think it was about 2017, their data set included, have been taken forward either for funded research or for some other translation into actual implementation, for example, through a PhD thesis or some other work. So there's a growing degree of credibility and tractability in the outputs of the process, which are really, really important. And one of the things that we've started to really emphasize, which we've heard here today, time after time after time, is that last stage about disseminating the outputs and making the outputs important. And we're building that into the process more explicitly, because that's really important. More questions later. It's much more important now that we actually hear from Zelalam and Jaya. But first, Bridget, I'd like to introduce the session for us.
Hi, everybody. So today we are going to hear about two different James Lind Alliance priority setting processes, both of which sought to amplify marginalized voices. One sought to amplify the voices of carers and patients in rural parts of India, and the other sought to amplify the voices of women with pelvic floor disorders in Ethiopia. And so I do want to highlight one difference between the two processes that you'll hear about. Is one is actually a national level priority setting exercise, whereas the other is a disease-specific priority setting exercise. But they both tackled the very important but difficult challenge of amplifying marginalized voices, which I know has already been discussed in the breakout group a little bit that I was in the last theme. And amplifying marginalized voices is something that is really important from an ethical perspective. Reasons for doing it involve reducing uneven power disparities, promoting self-determination, and also maximizing the knowledge used to set research priorities. But as these case studies are going to demonstrate, that amplifying marginalized voices itself will come with ethical challenges along the way. That's not my slide.
Oh, sorry.
That's okay. That one is, luckily. So there are 4 components that I think of when it comes to meaningful engagement, which is the area where there ends up being a lot of challenges when amplifying marginalized voices, actually getting them amplified in a meaningful way. And so the who initiates and for what purpose components speak to the fact that meaningful participation really encompasses defining and shaping the decision-making space. And then the bottom 2, who participates and how they participate, reflect the fact that meaningful participation is also about who is present, and then also whether they are able to say what they think and have their voices heard as part of the process. And with the 2 JLA priority setting processes you're going to hear about after I get off the stage, they had ethical challenges in relation to each of these different components. Around who initiates and who leads, there were dilemmas around steering committee composition. In terms of for what purpose, there were dilemmas around what the scope or the boundaries for what can be included in the priority setting process are, so what topics are on and off the table. And then also in terms of how people participate, there were dilemmas around, what happens when clinicians and carers and patients come up with very divergent priorities, and what do you do in those contexts? But now I am going to introduce our fantastic speakers. So Jaya Singh Kshatri is a medical doctor currently working with the Indian Council of Medical Research as a scientist at the Regional Medical Research Center in the state of Odisha in East India. He works primarily in geriatric public health with a focus on primary care and community-based interventions and implementation research. He manages a model rural health research unit, and you will hear his presentation first, and then we'll have Zelalam, who is an associate professor of obstetrics and gynecology at the University of Global Health Equity in Rwanda. He has more than 15 years clinical, academic, administrative, and research experience, and has been involved in teaching undergraduate obstetrics and gynecology at different universities in Ethiopia and Rwanda. And his research focus is on pelvic floor disorders. So without further ado, Jaya.
Thank you, Bridget and Toto, for the introduction as well as the help you have been providing on the case study. Being from a warmer climate, and in view of the weather here and the sumptuous lunch we had, I empathize with your biological need to fall asleep. I'll try my best to steer you away from that during my presentation. So this is a case study of how of the ethical issues we found when we attempted to set priorities which were decentralized in its nature, localized in its nature, for a central scheme. So I work for the Indian Council of Medical Research, which is the governing body for health research in my country. It's under the Department of Health Research in the Ministry of Health. Okay, thank you. So to set the context first, let me introduce you to this concept of model rural health research units. These are actual physical units of research with dedicated staff and a dedicated annual renewable purse of funding, which are established across the country. We have 30 states, and each of these states has one of such units. I manage one of those in the eastern part. One of the red dot is managed by me, but there are 29 other such units across the country, and we attempted to have a common priority setting exercise at the national level, because the scheme's goals and the scheme's objectives remain the same for all of these MRHRUs. The aim of such units across the country is to provide a platform for research among rural populations, because there was a feeling that I think previous presenters also emphasized that there is a feeling, at least in South Asia, that there are very overrepresented populations for research that are being seen in most of the studies from the region. So to take research to the rural population, that was one primary goal. They were supposed to provide a platform where any researcher can focus their work there. And they had very broad aims of improving health of rural population, which doesn't say much. It's not specific at all. It's very broad at the start. And hence specifying the priorities, specifying the aims of this project or the scheme was very important. Like I said, these are located within the campuses of primary healthcare settings, and they are intended to be, the products of this research are intended to be implemented in primary healthcare settings in rural areas. They function with a bare minimum staff of 8 people trained in multiple domains of health research, and they carry out research across these units. The outcomes expected from this were very ambitious. They thought it would not just improve the output of health research among these populations, but it would also lead to an adoption of more technology, more interventions which have been tested in tested in urban areas and implemented in rural areas. So with this context, there is this challenge now that the funding calls in India is still central in nature, meaning that there are central agencies that give out periodical calls for funding, and there is a need to identify research questions relevant to these fields of public health, clinical research, and health systems and implementation research, which are more relevant to the MRHRU scheme. So we thought a research priority setting exercise would be required to guide research agenda and funding decisions, because this also includes possibility of collaborating with multiple units and carrying out a nationwide study, which would be more attractive to funders. So with that in mind, we carried out this priority setting exercise where we included more stakeholders than what James Lind Alliance method suggests. We took a conscious call to include researchers in our exercise. We hence used a modified version of the JLA priority setting partnership, and we also, another modification of the JLA approach we did was we did not actually go for a consensus building workshop, because as you will see later on, we didn't believe that a consensus was always possible or necessary in such type of national broad priority setting exercises. So now let me go through the ethical issues, because the methodological aspect, Toto has already gone through the James Lind Alliance approach, and I think Zelalam will go in further detail on the methods of that. So the first ethical issue was related to the governance structure of the entire exercise. Firstly, who do we include in the steering committee? Like I said, we took a call to include researchers in our priority setting exercise. But what is the proportion of representation that we give to each of these stakeholders of policymakers, funders? We included funders as well, researchers as well as community members. So that was the first ethical issue that we were faced with. What is the proportion of representation from each of these stakeholders? We, like the JLA method, we started off with a survey, nationwide survey, which elicited a very, very broad and diverse range of opinions. So this was expected, because we thought, because it's a national exercise in a very, very diverse and large country such as India, we expected the diversity of opinion at the initial stages, but how do you reconcile that and summarize that at later stages? So that also was an ethical issue. We made a conscious effort to give voice to the community representatives, but then again, the issues we faced were the lack of expertise in terms of understanding the discussions, the language barriers that we have. When you speak of a country of 1.5 billion with over 40 official languages, language becomes a major concern which is not so for the English-speaking researcher groups or the educated group, but when we engage with the community members, language does remain a barrier. It had an impact on the quantum of participation from different groups of stakeholders in our steering group as well as later on. And the broad scope of the scheme and the broad range of opinions that we were hearing in the initial stages made us realize that it will be very difficult to arrive at very less number of consensus points later on. That leads to the next ethical issue about, even though we know what proportion of individuals from what stakeholder we will have, who will be those individuals, from which organizations or institutions will they be from? Because this is important for transparency and how the entire method is being done. We recognize that, yes, we need some people who are experts in priority setting exercises, who have done this previously, but where do we find them? Usually in India at least, we have this very national institutes which are located in urban areas and who have had, to be honest, and proportionate say in the health research agenda for the past 50 years or so. So we made a conscious decision again to exclude experts and exclude members from the steering committee who are based in urban areas, who work mainly in urban populations, who are from these legacy institutions, large institutions. So majority of our members of the steering committee were working in rural areas, staying in rural areas, and while we recognize that majority of the work on priority setting has been done outside of India, we felt that there may be a possibility of those views coloring our entire exercise. So we also did not include anyone from outside India in the priority setting exercise. The next ethical challenge we faced was setting the boundaries. When you have such a broad scheme, broad scope of your work being outlined, it's important at the beginning to set reasonably feasible boundaries for your entire process. There were many ways we could have done this, but we chose to categorize our priorities into descriptive type of research, developmental research, delivery research, and we avoided discovery type of research. Discovery research, mainly so these are all operational definitions that we used. Discovery research included only lab-based basic research or basic science research, which was beyond the scope of this MRHRU scheme. Descriptive research, we categorize all the epidemiological questions, epidemiological topics, what are the diseases that needs to be prioritized, what are the populations, and so on. For the developmental research, what are the interventions that can be prioritized, what type of interventions, among whom, and so on. In the delivery, we focus mainly on the health systems and implementation research, which was the key objective of this scheme, but that was one of the priority categories as well. The cross-cutting consideration for all of these categories was the MRHRU platform itself. Like I said, it has a very limited staff capability and limited resources, and so we had to be very conscious about the feasibility and the availability of resources as well as time, as well as expertise at this platform, and that was a cross-cutting consideration throughout the entire process. Now, the next challenge was, what do you do when you have so much of diverse priorities and you have very fixed, limited resources with you? So this was a national scheme with a predefined scope and a fixed purse, like I said, and the research priorities that we got were very diverse. While broad themes were identifiable from the first 2 rounds of survey, we realized that there is a need for more localized approach to rank specific research questions. So this was converted into a 2-stage exercise at that moment, and the similar one was done by the colleague from Peru, where they first identified broad themes of national importance at the national level, and each MRHRU, each of these 30 MRHRUs was then shared with this list, and they were supposed to carry out specific research question prioritization with their context, with their region in context subsequently. So the MRHRU scheme also has a major emphasis on capacity building, which may be true for most of such national schemes. They are not just for funding research, but also to build capacity in said research. So how do you reconcile with that? We were not able to include that in the priority setting exercise, and we felt it falls short of answering the need of the entire program. So therefore, we thought that involvement of managers of the scheme at national as well as local levels was very relevant from the very beginning, and they were included in all steps of the priority setting exercise. Now the last ethical issue that we faced were disagreements. We did expect disagreements. We tend to agree very less when we have very different views as we do in India, but we expected some divergences in opinion, but the level of dichotomy between two particular groups, what the patients or the community members are asking for and what the researchers are wanting to do, was very, very stark. This was something which we did not expect. The level of divergence was very stark. It was totally different, and even if they are talking about the same disease, the priorities were different within the disease. If the researcher wanted to work in, let's say, the laboratory diagnosis aspect, the patient wants better treatment. So that level of divergence between priorities was very stark. This required an intensive moderation throughout the process, and we had a good team of moderators, and they had to actually include this step of allowing only priorities which had some possibility at least of having some level of consensus later on to the subsequent step. So this curation is again a deviation from the James Lind Alliance method, but this was a necessary adoption that we did. While we did the survey nationally among all stakeholder groups, we also recognized that putting silos for rural health research, putting silos into priorities would be very difficult, and hence all our decision making has been very flexible from the very beginning. So what we conclude is that the first thing, it's not an easy task. This was new for me. I think you all agree. Priority setting exercise, though very necessary, is not at all easy. The amount of resources and time that it required was much beyond what I expected it to be. It's a complex task to identify such priorities, especially for national schemes, especially for heterogeneous and diverse and large countries such as India. The funding calls are usually given at the national level, but the funding calls itself need to have some level of flexibility so that local decision making on a proportion of that funding may be allowed to. What I'm speaking of is changing of or tweaking the objectives to meet their local needs. While the broad funding call may be for a specific topic, the objectives may be asked for very context specific and local in nature. So while it was necessary to have a broader set of national or regional priorities, it was equally important to have a localized and contextual set of specific research questions. It was also important to identify what is not a priority by factoring in patients' need and what the community thinks about it. Thank you. That was my time.
We'll take questions after Zelalam's presentation, if that's okay. So note down anything that you wanted to ask Jaya, and we'll do it in the panel afterwards. Zelalam?
Good afternoon. So I'm going to share you very specific. So far, we had talk about national priority setting partnership. This one is very specific, disease specific, as well as it's not a national one. It is really subnational. It is a priority setting partnership exercise focused on pelvic floor disorder. So before this, you might see some unpleasant pictures because, yeah, and I got consent for the pictures. Yeah, good. So this priority setting partnerships focus on pelvic floor disorder. Pelvic floor disorders contain pelvic organ prolapse, as you can see on the picture. So protrusion of genital organs, and urinary incontinence, basically non-fistula urinary incontinence, because when we set this priority setting partnership, we found fistula is more explored, more has been said, so we focused on non-fistula incontinence and fecal incontinence. Basically, we included patients with urinary incontinence and pelvic incontinence. So the setting is in Ethiopia. It is at the Horn of Africa, and from Ethiopia to the northwest part of the country. So when we see the context of pelvic floor disorder, it is a major public health problem in Ethiopia, basically even in low-income and middle-income countries. It is associated with emotional, physical, and social and economical suffering of women and their families. However, much has not been done in making healthcare service available and accessible for this group of patients. So it is very important to give patient-centered solutions, and generating robust evidence is really very important. So you have said, it has been said in the morning, a lot of research has been done, a lot of resources invested, but many of the researches are done by, or the research questions come from researchers, pharmaceutical and technology industries. This created a mismatch between uncertainties researched and the questions about the researches about the end users. So involving end users are really important. That means in our context, patients, carriers, and healthcare providers are really involving them are really crucial. So we used James Linda Alliance classical method. We used all the steps by making some modification, context-dependent modification. And this kind of, based on the registered GLA methods, it is one of the few priority setting partnership using James Linda Alliance. So as Toto has explained it, it has 7 stages. We have gone through all these 7 stages. The first one is forming steering groups. We formed the steering groups from patients, carriers, and other stakeholders, clinicians, and people working on this problem. Then the next, here you can see this is the first meeting. Basically, the process was oversighted and guided by the advisors of James Linda, Toto. You can see her on the picture. So here you can see pictures, our steering committee members from patients, carriers, and stakeholders and clinicians posed for a picture after the first steering committee meeting. On this meeting, we set even the title of the project. What should it be said? Because pelvic floor disorder is really, it is more a technical term. So we put a term for that in the local language, as well as we translated that into genital prolapse and involuntary leakage of urine as a project title. Then we discussed also how should we do this, all the process. Then we went to the gathering of uncertainties from the patient's carer by going to their households, and later we summarized that and changed it into research questions. Then after we checked against available evidences. Then after with those evidences are not found, we went for interim priority setting. Then we haven't done yet the workshop to finalize the priority setting exercise, and the stage 6 and 7 are not yet done. So you can see on the picture the trend, local nurse went to the household of a woman with pelvic floor disorder and asking her about her questions regarding the problem she has. So by doing this, we managed to identify, the aim is to identify 10 answered questions, but so far we identified the top 20 research questions. And this PCP exercise on the first survey, about 392 participants were involved. Of these, 251 were patients, 69 carers, and 72 health professionals. Then after the evidence check on the second interim prioritization, about 124 participants were involved. And this one, we asked on the first just a question. They can say anything what they want in their own words. On the second one, we went to them with lists of questions so that they can re-rank that. So these are some of the questions we come up about. These are the top 10 from the interim prioritization, but we have like 20 which needs a workshop and have face-to-face agreement to come up with the 10 top uncertainties. And since it was difficult how to go about, we were making different consultation with patients with the problem, how to do it, how to communicate with them. So while we run this uncertainty, priority partnership, we uncovered some ethical issues which are equality in understanding, transparency, and the other issue is going back to untreated women for re-ranking. So what does equality in understanding? Of course, we allowed all participants to have equal opportunities and rights. The steering committee was organized with equal representation from patients, clinicians, carers, and other stakeholders. We did it with the guidance of this steering committee members. The steering committee members, they have better understanding because they were selected purposefully. But when we come to the patients and the carers, we involved them. So, we give all this opportunity. They had difficulty to understand really what it is about, what research is. So for that reason, just only we let them to speak out what they have in their mind. And we recorded that. And that record was summarized and synthesized externally by the research associates and the research lead. Of course, we have tried to make To avoid inconsistency between the research associate, we did some samples and checked for consistency, and we did the summary and the sentences independently. So, however, the other participant, the gynecologists, they were participated as clinicians and other health providers were involved. They can manage to write exactly what they want to have investigated. They put their uncertainties clearly, which is not really true for the patients. So here we found ethical issue related with equality in understanding. The other issue is transparency. Of course, we have tried to be as transparent as possible. We explained for the patients, but though we tell them that this is something related with research in the way they can understand, but they were really focusing on their treatment. They are not really interested about what we are talking to them. So, because these people, they are living deep inside in the village. So when someone from a city or someone they think from a health institution, when they feel as they are going to get the care. So they say whatever you ask them, they answer. So this was really very difficult. Are we really transparent to them? We may tell them, we told them that we are not there to treat them. We are not there to take care of them. We are there to have their uncertainties. But they don't care about it. So can we say that really we are transparent? This is another issue. So you can see another picture in which we went back. This woman, she was involved on the first survey. Then again, we went back for interim prioritization. She was not really treated. So the other issue is going back to the same moment to ask them to prioritize. Should we treat? What about those who are not involved with them? Of course, we facilitated for some of the participants who had really difficulty and some kind of emergency related with the problem they had. So in conclusion, so tools proven in global north is not without consequences of ethical dilemma. However, it was possible to develop research priorities representing participants by making context-dependent methodological modification. We managed to identify so far with the survey 36 questions which are not really answered, and of these 20 plus were prioritized, which will be ultimately help this woman, we hope. Methodologically proven ways of research priority setting partnership for global souths is required while maintaining the basic principles of priority setting partnership. Thank you very much for your attention, Toto and Bridget, for their support during our case study preparation. Thank you, everyone, for your attention.
Perfect timing, both of you. Could we invite you to sit on the panel? How long have we got? 10 minutes for panel or 15? Okay, we have 15 minutes for panel discussion. I saw a hand up over there. Would you like to make sure you say your name? And there's another hand here next. Say your name, please, and address your question to one or both of them, please.
Hi, Pei Young here from Bangkok. So this, I guess it can be to either of you. So I work quite a lot with community members as well, some of them from rural populations. So how can I imagine asking them what your research priorities are or what your unanswered questions are, it's quite difficult. So how do you actually phrase the question? The actual phrasing, I mean, of course you have to translate for me, but how did you phrase it to get the answers you wanted? Thank you.
Thank you very much. In fact, this was the difficult part. At every step, we had difficulty, and first what we did, I mean, is we did a piloting. Even it was difficult, I mean, for our local health provider, whom we selected and trained to ask this question. So we did first piloting. On the piloting, when we go there, we try to be as detailed as possible on the guide. That was prepared with the help of the steering committee members. They are, of course, some of them are from the similar setting with similar problem. But on the first, on the piloting, it didn't work. Of course, we have also a voice recorder. So on the next, we decided only to give them simple questions. So the questions were, what ideas or questions you have related with your problem as a cause. So they talk about what resulted because of this. Okay, we record that. Voice recorder is being used. Then the next was about the process of diagnosis. So what difficulty you had during the process of diagnosis? How was it diagnosed? What questions you have? It's not literally research, because it's very difficult for them to teach them what research is. But we made them to speak any question related with the process of the diagnosis. And the next was about their treatment. We led them to talk about their treatment. And the fourth one was about the impact resulted, that problem resulted. Then it was recorded. This is the way we asked them, because it is very difficult. What research question do you have? Even what question do you have is difficult for them. But to say what they have in their mind about their problem, using these four pillars we used. That's how we try to figure out and have their ideas. And we sensitize that from the audio recorder. That's why, but the ethical issue here, really we grasped what they wanted to say. Did we misquote them, their idea? That is, the issue. Okay, thank you.
Yeah, I agree with most of what he said. One additional point I would like to add here is that there is a different set of expectations from the community members, and being very clear and honest and transparent about the process itself is important. There is a need to differentiate your line of questioning, your line of eliciting responses, in the sense that what is research and what is a health service, that delineation is difficult, and we need to be very clear. Okay, so this is the question about research, and what they understand in turn is, okay, what will I get out of it? What health services will be improved if I participate? So that is through very clear communication at the beginning about the goals of this entire process, and transparency helps a lot.
Thank you. Question up here at the front.
Yeah, hello. This is Florencia Luna from Argentina. Well, this has to do with your answering the question and to the ethical issues he was pointing out, and this woman that wasn't taken care. So, though I am well aware that delivering is not part of the issue, It is an ethical issue, because if you're coming back or you're requesting these persons to help you, and even if you try to be as transparent as possible, we know, for example, in research ethics, that there is therapeutic misconception. It's very difficult to really realize the difference. Yeah, you are in need. There is this person that is coming from the cities, and the expectation that's there, it's really a complex issue. So my question is, shouldn't we consider some way of getting some at least minimal care, referring these people to somewhere, helping them getting care? Even we are asking for what they do not have, but there might be, and we have to do research, but there might be some essential issues I'm sure they are not having. So this is my question. Shouldn't we make room for this and have a more even complex, or, I don't know, sophisticated way of allocating resources?
Thank you.
Okay.
Good question.
Yeah, thank you very much for your nice question. Yeah, that's true. But this participant, this woman with pelvic organ prolapse, we identified them. They were already on waiting list. They were referred to a setting where they can get the treatment, because we don't have the conservative treatment, which can be delivered at the level of local health facilities, is not really available in Ethiopia, like pizzeria. It's not really available. Mainly, the treatment is surgical. So these women already referred to a setting where the surgical care is available, and they were on waiting list. So that we don't already, they are referred, so they are waiting until they get called from the facility. Yeah.
So, if I could put a counterpoint to that, while participant protection is an inherent component ethical issue in most type of research, even for priority setting exercises, where does it stop? So let's say for a broader research priority setting thing that I did, the participants were from the community who had hypertension, who had diabetes, and these were not acute things, acute concerns. But as a researcher or as the investigator, how far should I go to ensure that adequate care for such diseases are to be met? And the decision, I think, is best left to the individual ethics committees or the IRBs, who can take a case-to-case call on what level of participant protection is required for what type of research that is being done. So it may be more relevant, the question is much more relevant for a situation like pelvic floor disease patients, but I think if I consider priority setting exercise in general community members, the level of protections cannot be too heavy on the too heavy a responsibility.
Oh, lots of hands. You pick one, Bridget.
Maybe the gentleman right in the front.
Thank you so much. Thank you so much for your presentations. I just would like to ask Dr. Zelalam that I appreciate your admission that your respondents or informants didn't understand properly what the research is all about, and you questioned about transparency and equal understanding and all that. So I'm just wondering, so if you have to do it again, how do you like to do it, to solve these problems? If any regrets that you think that can be done in the future research? Because if they didn't understand that, the whole idea of even informed consent is in question. I mean, it's not about prior setting, but about doing informed consent, informed research, or with informed consent of informants. So what do you suggest, in such kind of rural context, to do research in a very with informed consent? What do you suggest? I'm thinking of, for instance, you could have even done, rapid ethical appraisal, just to understand the concepts that the rural people use to describe this problem, solutions, and all that. That could have been done as one solution. But I don't know, what else can you suggest also, perhaps, to do maybe better research in the future?
Yeah, I mean, it's a very good question. Thank you very much. It is very difficult to come up with a recommendation, but anyhow, as I put it on my slides, despite all these issues, we managed to, we believe that we managed to grasp their questions. But that is up to us to change to a research question. It's not the patients. So we need to make, explanation as sufficient as possible for the patients. So we can use different methods. The other thing is the training we provide for the data collectors, because we observed the difference at the piloting, because we use the same data collectors. Even for the data collectors, even though they are health professional, it is very difficult, to understand the research concept. But as they stay along with us in the process, even they started to come up with how to explain for the women. Otherwise, it's very difficult, to come up with recommendation right now. Just one recommendation. Just try your maximum effort by changing the ways to give some clue for the woman what you are doing. Or you need to find a way to make them to say what they have in their mind. Because on the piloting, I want to explain here. On the piloting, even just they stuck. They don't say anything. What are your questions regarding your problem you have? They stuck. So we simplified it. So we were learning a lot. So, as continuing the exercise by considering still women living in under privileged setting with less literacy can have they put forward their uncertainties. The message which should be taken for us to me. Thank you.
I think one really quick question. Thomas, it's quick.
My question cuts across how to really engage, marginalized voices and more so people who are already vulnerable, they're desperate, and in many cases, they're likely to suffer from the therapeutic misconception that has been talked about. When you engage this group of populations in priority setting, where they're already desperate, how authentic, in your view, how authentic is priority setting when you deal with this kind of population? Is it a tick box, or do you think you end up really getting authentic information that informs the true picture and the authentic process that you really endeavor to achieve? Thank you.
Do you want the answer to be quick as well?
Yes.
Okay. So it should never be a tick box. I think that much we all agree. It should never be a tick box. You should make the most possible attempts to engage with marginalized communities. But it is also important to remember that such representations are a part of the entire process, and the process is not 100% dependent on this group of participants alone. So while it is also very important to give them voice as much as possible, like Zelalam said, make them understand the entire process, make them participate. They usually don't participate. That's also what my experience is. If you make them make a group of 10 people sit in a room and 2 of them are from the marginalized communities, as you say, the level of participation will not be same across all participants. And how do you encourage that? There is no one gold standard answer of how to do it. I don't think anyone can give you that answer. It is very context specific for what you are doing and who that marginalized communities are that are being involved. But this is one part of the problem. The entire process depends on many other aspects, and those are also equally important to be looked at.
Okay. Yeah, it is just now. It is about the checking box. It's not like that. It is an open one, so they say whatever they want in their perspective because they are disparate. That's also, I mean, from their desperation, whatever they said, that's a question for us. But we have a scope again. There are questions out of scope, so we don't treat that one. But if they said anything in the scope, that will be taken, and we check against the existed evidences. Then if that's not answered, we will take it, I mean, as an uncertainty. Okay, thank you.
Thank you very much. I think if you want to save all your questions, because I know there are lots of hands for the breakout group discussion, that would be great. Just one reflection from me listening to this, which is that through research priority setting, even going into the community like this and talking to people with lived experience, you know, the marginalized voices, just that act of measurement, just like in physics, I'm a physicist, just that act of measurement actually disturbs what you're measuring. It makes a change. It creates a ripple effect. And I think we should be cognizant of the fact that when we go in and talk to people about these things, wherever it is, that we can't just walk away and pretend nothing's ever happened. Something's happened because you've gone in there and talked to people. And what are the consequences of that conversation that you've just had in the community? And you know, that's something that's certainly happened in these 2 cases. And it'd be interesting to see how that kind of theme might be considered.
So let's thank our 2 speakers for the day, and then